All right, so welcome everybody today to, it's already November 3rd. This is our family medicine grand rounds for today. The activity code, should you want to register for CME credit, is right there, the 1008-7603. You do need to make sure that if you haven't registered, before you send that code, make sure you send your email address first, and then you'll want to text after that. You'll text attend, and then you'll not put the plus sign, but you'll put the 8-digit code that's listed there. So if we can go to the next slide, it should show a picture for y'all. It shows right there on the right hand side that you just text your email address, and then next after that you should get a message, but you'll just text attend and then the code for today, which is listed there for you. I'll be putting that in the chat again as well. But if you have any issues with that, please feel free to reach out to me. Next slide. So as we get started here, I just want to remind everybody, make sure that your microphone is on mute unless you are commenting or joining in the conversation. Dr. Shin has mentioned that she is okay with questions in the chat box. I'll be moderating that for her. So if you have questions, make sure you put them there. But otherwise, if you could help us to remain engaged in the session, and then also at the end of the session, I will be putting the evaluation link if you can help us get some feedback on the presentation today. Next slide. So this is the South Texas Regional Family Medicine Grand Rounds. We just want to mention that we are partnered with the South Central Area AHEC, and that our mission statement is there for you if you'd like to take a look at that. Next slide. CME transcripts, those are available through the UT CME office. The website is listed there. You will need that if you are wanting to get AFP credit for viewing this presentation. So make sure that you do register your credit tonight before midnight, but if you need a copy of your transcript, you'll just need to go to the website there. Next slide. So as mentioned, we do offer credit through the AFP for this presentation. If you have any issues or concerns, you can contact them, or you can reach out to me as well. Next slide. We also want to make sure that we do let you know that we are addressing the nationally established physician core competencies that you see there below. So if you have any questions, just reach out to us, but we want to make sure we point that out, that is the goal of our presentations. Next slide. And then I do need to mention that Dr. Esther Shin and also her preceptor for today, Dr. Siddiqui, they have no financial relationships with ineligible companies to disclose. She is going to present for us today. She is one of our residents here in the program, precepted by Dr. Siddiqui, but she's going to be talking to us today about aspirin use for primary prevention. So I will let her get started.
Hi, everyone. Welcome to today's Grand Rounds. My name is Esther Shin. I'm one of the PGY3s here at the UT Health San Antonio Family and Community Medicine Residency Program. So like Nicole said, I will be talking about aspirin use for primary prevention. So the objectives that we will discuss today is to review older and newer studies on aspirin use in primary prevention, identify current USPSTF guidelines, identify current ACC and AHA guidelines, and then discuss the use of both USPSTF and ACC/AHA guidelines. So just a little bit of background about the study. So about 30 years ago, the first systematic review suggesting a role for aspirin in cardiovascular prevention reported relative risk reduction of about 15% for cardiovascular mortality and 30% for non-fatal myocardial infarction and stroke in patients with known vascular disease. More recently, an individual patient data meta-analysis of 8 trials showed reduction in cancer deaths for patients taking aspirin for 5 or more years, and another study reported reduction in incidence of colorectal cancer in aspirin users. It also showed that in both primary and secondary prevention populations, aspirin users had significantly increased risk of major intracranial and extracranial bleeding. So the IPD, so the individual patient data meta-analysis, is a specific type of systematic review. So rather than extracting summary data from study publications, the original research data is sought directly from the researchers responsible for each study, and then the data can be analyzed centrally, and combined in meta-analyses. So most of the older trials were set in Europe and USA, and they recruited patients prior to 2000, which is were widely used, and there was a lower rate of colorectal cancer screening. As we all know, statins have been shown to be effective in primary cardiovascular prevention, and colorectal cancer screening has been shown to reduce both incidence and mortality of colorectal cancers. Recent trials during a time when statin use in colorectal cancer screening is more widespread found similar or some increased harms, but fewer benefits for aspirin as primary prevention. So this particular article, they had looked at basically two subsets, older studies comparing to newer studies. So the newer studies, they looked at limited meta-analyses of 4 recent large randomized trials, and all the patients were recruited from 2005 and onwards, and they compared to results of previously published meta-analyses. Of the individual patient data meta-analyses. So for the newer studies, the most recent review was from 2019. So of the newer studies, they compared, this is the following criteria: randomized control studies that compared aspirin with placebo for primary prevention of cardiovascular disease. The population of interest were adults with no history of vascular disease, and the population of interest were recruited from 2005 onwards, which again characterizes the modern era of widespread statin prescribing and colorectal cancer screening. So this is based on studies that show a large increase in the prevalence of statin use after the publication of the 2001 National Cholesterol Education Program Adult Treatment Protocol 3 guidelines. So the data items that they had looked at, these are the extracted outcome data as the number of participants with each of the following. So it's major adverse cardiovascular events, MACE, which includes cardiovascular death, non-fatal stroke, and non-fatal MI, mortality, all-cause cardiovascular and cancer, cancer incidence, bleeding, including major hemorrhage and intracranial hemorrhage, stroke, which included any stroke, ischemic stroke, and hemorrhagic stroke, and each of those were then subdivided into any fatal and non-fatal, and then finally MI, which was divided into any fatal and then non-fatal. This study used an intention to treat. So the intention to treat basically means that study participants are analyzed as members of the treatment group to which they were randomized, regardless of their adherence to or whether they received the intended treatment. And then they also had used the Cochrane risk of bias tool to evaluate the quality of the 4 contemporary studies. So we're going to talk about the newer studies first. So of the newer studies, there were a total of 60,604 patients. So they had identified 6 reports of 4 large randomized control trials. The 4 being the first one, aspirin in reducing events in the elderly, aspirin to reduce risk of initial vascular events, a study of cardiovascular events in diabetes, and then the Japanese primary prevention project. All the newer trials were randomized and with concealed allocation and adequate follow-up. So 3 of the studies, the first 3 listed there, were masked for both participants and outcome assessors. The JPPP study, neither participants or assessors were masked, but they felt that it didn't introduce significant risk of bias given the outcomes in question. So overall, the risk of bias was assessed as low for all 4 studies. Now, comparing those studies, the older studies, there were two main categories. The individual patient data meta-analyses of 6 studies, which had a total of 95,456 patients, and they were recruited from 1978 to 1999. And this group assessed for vascular and bleeding outcomes. And then the second one was a meta-analysis of 8 studies. And this had a total of 25,570 patients recruited from 1978 to 2002. And this meta-analysis assessed for the effect of aspirin cancer mortality. So here it shows the different patient characteristics of the patients who were part of both the newer and the older trials. So if you see here, the first one is going to be the individual patient data meta-analyses that assess for the vascular and bleeding outcomes, while, oops, where did it go? The second study here, the 2011 one, is the one that assessed for the cancer mortality. So here, basically it shows that the patient population differed considerably between the older and the newer trials. So for instance, we're comparing the first meta-analysis here compared to the newer trials. So the newer trials, overall, patients seem to be older, 69 years versus 56 years old. So here, 69, and this is total average of all the newer trials together. So we're looking at 69 versus 56 years old. Patients in the newer trials were somewhat less likely to smoke, 12% versus 16%. And then patients in the newer trial were more likely to have type 2 diabetes, 35.5% versus 4%. Now comparing to the second study, which assessed the effect of aspirin cancer mortality, the newer study patients seem to be older, just like the first one, 69 years old versus 60 years old, were more likely to be female, 47% versus 29%, and less likely to be smokers, 12% versus 35%. And then on a quick side note, so as you can see here, for the older studies, statin use was not reported in the older studies. All right, so this is showing a summary of kind of the results comparing the older studies to the newer studies. So here overall, there's no difference in aspirin and placebo groups in any of the mortality outcomes in both the older and newer studies. There was statistically significant reduction of major adverse cardiovascular events, as you can see here. And then there was also clinically and statistically significant increase in the risk of major hemorrhage in both the older and newer trials, and then increase in intracranial hemorrhage in the newer trials, as you can see right here. In the older study, there was a reduction in the risk of cancer death, but that was not seen in the newer studies. Let's see. And then the likelihood, here we go, the likelihood of any ischemic stroke was identical in both the older and newer studies, but it was statistically significant in the newer studies. So here, this is just showing the outcomes from just the older studies. It shows the significant relative risk reductions and increases. So as you can see here, the relative risk and the significant relative risk reductions include cardiovascular death, MI, fatal or non-fatal, and then MI, non-fatal. But as you can see here, like fatal MI, there is not a statistically significant reduction. And then as far as relative risk increases, there was an increase in major hemorrhage and then stroke, both fatal and hemorrhagic. outcomes from the new studies, the only relative, there was a relative risk reduction of cardiovascular death, which is very mild. And then there were significant relative risk increases in intracranial hemorrhage and major hemorrhages. Oops, sorry. All right. So this table summarizes the absolute risk increase or reduction, the number needed to treat or number needed to harm, and the events per 1,000 persons over 5 years for outcomes where there was a statistically significant difference between groups. The lower risk, relative risk of major adverse events, cardiovascular events, equates to an absolute risk reduction of 0.33, which is a 95%. I'm so sorry. Here we go. And then for any ischemic strokes corresponds to an absolute risk reduction of 0.25. And then in regards to harm, aspirin was associated with an absolute risk increase for intracranial hemorrhage of 0.7% and major hemorrhage of absolute risk increase of 0.24%. So this kind of gives us all the information of what they had found. And so overall, both in the newer and older studies, aspirin for primary prevention found no mortality benefit and significant increased risk of major hemorrhage. And then in both studies, both the older and the newer studies, there was a lower risk of major adverse cardiovascular events, which corresponds to a number needed to treat to prevent one event of 303. So this study slash analysis focuses on 4 recent large studies that collected data since 2005. And so therefore, I guess the point of this is showing that it provides clear guidance to primary care physicians regarding what their patients can expect in terms of benefits and harms in the contemporary era. In the newer studies, it failed to find evidence for an important potential benefit of aspirin, which is the reduced risk of cancer mortality. And some of the explanations for the failure of aspirin to reduce the risk of cancer death in newer studies, they focus on 3 different possibilities. First thing is that the older studies were less likely to have undergone regular cancer screening. So the US Medicare didn't pay for colorectal cancer screening until 1998. Colorectal cancer screening was largely started in the late 1990s or 2000s. Mammogram use was not widespread until the late 1980s. And then in general, overall cancer survival rates have increased over the past 30 years. And that could be due to lots of different aspects, including advances in technology. So these factors may have dampened any potential benefit of aspirin for cancer prevention by reducing the overall risk of cancer death, and then therefore the absolute benefit possible. Another explanation or limitation is that the short duration of the newer studies. So the older studies, like I said, the meta-analyses kind of, patients were recruited over a longer period of time. As I had mentioned before, I think one of them recruited patients from 1978 to 1998, and the other one was 1978 to 2002. And so the newer studies, though, so the first 3 studies were over a 5-year span, and then the last JPPP study was 7.4 years. And so this is most likely not long enough to see the benefit in terms of cancer mortality, which didn't appear until after 5 years of follow-up in the IPD meta-analysis in the older study. And then one final limitation of the analysis is the differences in inclusion criteria for some of the outcomes. However, the relative risk increases were consistent. So they had reported 22 individual and composite outcomes. So it is possible that some of the findings occurred by chance. So management, as a whole, management of cardiovascular disease has changed considerably from the 1980s to the era after 2005. And so, as I had mentioned before, the publication of the 2001 National Cholesterol Education Program Adult Treatment Protocol Guidelines led to a large increase in the use of statins, which primarily reduces the risk of non-fatal MI when given as primary prevention. So the evidence of aspirin's benefits and risks in primary cardiovascular prevention is reflected in variable recommendations across different clinical guidelines. So the first is the USPSTF recommendation. So currently, and this has been, I believe, since 1996, the current recommendation is adults aged 50 to 59 with a 10% or greater 10-year CVD risk. They recommend initiating low-dose aspirin use for the primary prevention of cardiovascular disease and colorectal cancer in adults aged 50 to 59 who have a 10% or a 10-year CVD risk and are not at increased risk for bleeding, have a life expectancy of at least 10 years and are willing to take low-dose aspirin daily for at least 10 years. And then the grade C recommendation is for adults 60 to 69 years. And it's basically, having patients who are people who are not at risk for increase for bleeding. And this is more, it's kind of a toss up of there are benefits, but there's also some risk associated with it. And I'll go back in just a few minutes or in a little bit to tell you kind of distinguish what the different grades are. And then the current ACC and AHA recommendation currently shows that low dose aspirin should be considered for primary prevention of ASCVD among adults 40 to 70 years who are at higher ASCVD risk, but not at increased risk of bleeding. So I'm just going to go back real quick. So there is actually, before I go into that, the grade. So grade B, as you can see here for the current guidelines, grade B basically the USPSTF recommends the service. There is a high certainty that the net benefit is moderate, or there is moderate certainty that the net benefit is moderate to substantial. And so for practice, they offer, you should provide this service. However, currently, there is a new USPSTF recommendation in progress. And so this new recommendation is the decision to initiate low-dose aspirin use for primary prevention of cardiovascular disease in adults ages 40 to 59 who have a 10% or greater 10-year CVD risk should be an individual one. Evidence indicates that the net benefit of aspirin use in this group is small. Persons who are not at increased risk for bleeding and are willing to take low-dose aspirin daily are more likely to benefit. And so this this is in progress currently. There's a few different steps that is necessary to change recommendations. And so this recommendation that's in progress is now rated a grade C. And so grade C, the definition is the USPSTF recommends selectively offering or providing the service to individual patients based on professional judgment and patient preferences. There is at least moderate certainty that the net benefit is small. So as far as suggestions for practice, offer or provide the service for selected patients depending on individual circumstances. And then as far as in patients 60 years or older, the USPSTF recommends against initiating low-dose aspirin use for the primary prevention of CVD in adults age 60 years or older. And a grade D, the definition of a grade D recommendation, the USPSTF recommends against the service. There is moderate or high certainty that this service has no net benefit, or that the benefit or the harm outweighs the benefits. And so as far as suggestions for practice, we discourage the use of this service. So this is currently in the works to get approved. I I think if Dr. Hine, if you want to share, so there's a few different process or steps in the process to update a recommendation, just kind of a quick little sidetrack. And so it is, you do a draft research plan, a final research plan, and then you give a draft recommendation. And then after some time, you have a final recommendation. And so we can talk about that a little bit more after we talk about this, but these are the current, so this is the recommendation that's in progress, but these are the two recommendations for ACC-AHA, and then the USPSTF is to initiate aspirin for primary prevention in the cardiovascular disease and colorectal cancer. So the key points of the article or the of this current analysis is that widespread statin use and cancer screening may alter aspirin's benefits and harms. Aspirin reduced major adverse cardiovascular events, but increased bleeding risk. Mortality, cancer mortality, and non-fatal MI were not reduced. And then aspirin for primary prevention should not be recommended in the modern era. So in a modern era, so, which they define as after about 2005, where there's a widespread statin use and population-wide cancer screening, aspirin no longer reduces the absolute risk of cancer death or MI when given as primary prevention. So for every 1,000 persons who uses aspirin for primary prevention for 5 years, there will be 4 fewer major adverse cardiovascular events, 3 fewer ischemic strokes, but there will also be 3 more intracranial hemorrhages and 8 more major bleeding events. And so, like I said in the last, so this study concludes that aspirin for primary prevention should not be recommended in the modern era. So at this point, I want to ask you, ask all of you, the participants. So what does this mean for primary care physicians? The current recommendations are still recommending that we initiate aspirin for cardiovascular benefits, as well as colorectal cancer benefits as well. But now that, we see that the USPSTF is coming out with newer recommendations and studies such as this, what do you guys think, given this information? You can unmute yourself if anyone would like to share.
Hey, Esther, this is Yun. I would wait for the final recommendation from USPSTF, but definitely there's evidence suggests there's more risk of bleeding. So I would be careful not to start someone on aspirin as a primary prevention. But if the patient's already on it, then I'll evaluate whether there's risk of bleeding, and also keep the patient updated, say, hey, there's changes in the recommendation. Stay tuned whether you should be continuing taking this aspirin or maybe stop it.
For sure.
Yeah. Mm-hmm.
Yeah.
I actually just had, oh, go ahead.
There you go.
I don't know who's that. I just actually had a conversation with one of my patients about this yesterday. She was like, I think she was in her late 40s, no comorbidities, and was told she's been on aspirin for like 5 years. And I told her that like new guidelines really aren't recommending this. And I told her the risks, but we did a joint decision making. She was on quite a bit of medications in general, so she decided to stop it. But we just kind of talked about the benefit and the risk together. And then she made the ultimate decision at the end that she wanted to stop it. And, so that's kind of how I've approached it.
Yeah, no, I think that's I think that having that conversation and making individualized decisions is very important right now. And so I agree with all of you guys so far saying, there aren't the new guidelines haven't come out yet, but so I think having those conversations with patients is very important. I think someone else is going to say something.
It was me. It was Marissa. Basically, I was just going to say the aspirin discussions. I agree with the other two people in that I don't really initiate it for primary prevention for anybody, and I do question it, especially if it's just a diabetic patient. That was even previously, I think, discussed that maybe give it for diabetes patients for prevention. But yeah, I don't initiate it, and then I question if it's on, and just have the discussion with the patient.
Okay. Anybody else have any input?
I see Dr. Fortune did mention that a lot of patients already have their mind made up either way.
Yeah, I think that is true, especially I think, especially if patients have been on aspirin for many years. I think not just aspirin, but you know, a lot of medical decisions in general. It's like, well, I've been on this medication for this long and it's been working for me. Why would I stop? And so I think that it's very important to have, you know, good open discussions with our patients, discussing what are the risks, what are the benefits of aspirin. And, you know, whenever this new recommendation comes out, then we can, you know, present patients with this information and say, well, you know, the newer recommendations, this is what it's showing. It shows that, you know, you can use it, but you know, if you have, it's a conversation that we need to have together and figure out, does this recommendation going to be more beneficial for you, or is it going to be more harmful for you? And I think the key point of that is for you, you know, for that individual patient. But I think the biggest thing is that what's been consistent through all the recommendations is that if anyone who has an increased risk for bleeding, then they should not be on it. And so I think that's very important to discuss those factors, and making sure to get that information from patients to assess whether they are at risk for bleeding or not.
Excellent presentation, Esther. Many of our patients have comorbidities, and sometimes it's difficult to know if they're on aspirin for primary prevention or secondary prevention. Do you have any thoughts in terms of what are sort of on the other side of the equation? What are the uses for aspirin for secondary prevention, and what are the main indications from that perspective?
So basically, for you know, this study, it showed they were focusing on patients who had no vascular disease, and so that's, you know, we're talking about for primary prevention. But as far as aspirin for secondary prevention, you know, patients who have cardiovascular disease, who've had strokes in the past, you know, so we're looking at the benefits. And so I think it's a different sorry, I lost track of what the question was.
Well, let me restate it for you.
Okay.
Many of our patients are not asymptomatic, and they do not have or free from cardiovascular disease. So I think even if they haven't had a particular event, at what point can you make that decision that, okay, you still don't have any events, or maybe the TIA you had or the MI you had was not a big deal. Maybe we need to stop your aspirin. So I don't have an answer. I'm just trying to promote some conversation, because the reality is that most of our patients have some form of comorbidity that makes the discussion less clean than this particular study, or the people who were enrolled in the studies were by definition not having any comorbidities related to cardiovascular disease. So yes, it applies to those who are clean, but what about the ones in between? And I
For
don't,
sure.
maybe there's no answer, but I just wonder that out loud.
Yeah, no, for sure. I think I do agree that, you know, our patient population, majority of our patients do have risk factors, and they do have vascular disease. And so I think at that point, I think it is still very important to, I also don't know what the right answer is, but I think it is important to figure out what are the risk versus benefits, and, you know, are the risks greater than the benefits that they'll be getting from aspirin use. And I think that the USPSTF recommendation doesn't, you know, necessarily say that just for you know, primary versus secondary prevention, but looking at their, you know, cardiovascular risk, their ASCVD risk, and then are they willing to use aspirin for at least 10 years? So I think that as far as, you know, whether it's used for primary versus secondary prevention, I think the conversation of talking to the patients of the risk versus benefits, I think, are a little bit more important for patients with, you know, who have risk factors to determine whether, you know, it's appropriate or not. I think for primary prevention, it sounds like that the risks are higher than for benefits, especially if they have no history of any kind of cardiovascular disease. That kind of answer? I don't think it does, but
Yeah, well, and I think the difference is not necessarily risk factors, because all of our patients are going to have risk factors, but it's whether or not they have the condition that makes aspirin more likely to be beneficial than harmful. So it's something to keep in mind, because just because you have the risk, it doesn't mean that you have the condition. And in the US Preventive Services Task Force, by definition, there is asymptomatic, not disease laden. So I think that's part of the challenge. But I think your presentation was excellent. Thank you for doing it.
Thank you. Does anyone have any questions? Think. So if briefly, Dr. Hyan, do you mind, since if you know, you are part of the USPSTF crew, just briefly describing, you know, with this new recommendation in progress, kind of a little bit more in detail about the process of developing an updated or new recommendation?
I can't, because I'm not there yet. I will start in July, on January 1st.
Oh,
But
got it.
I think in general, I can comment that, you know, the current draft is a result of a very extensive evidence review that is in the website that you can access now. And right now it's in the middle of public comment. And each of those public comments are going to be taken into consideration before the official recommendation is published. So that's part of the process.
Yes. And so like Dr. Hyan said, if you go to the website and you click on the, you know, current recommendation statements, it'll give you draft recommendation statements and show you kind of each process that's happened so far. And just like Dr. Hyan said, until I think November 8th, they are allowing for public comments that they'll review. And then, you know, so they've got their draft recommendations, they'll look at all the comments, and then from there, they'll give their final recommendations and evidence summary. And so it's pretty far into the process. And as far as initially, when they give their research plan, they also allow people to give comments. And so they take all those into consideration as they're making these recommendations, and whether it's updates or new recommendations. So I think it's really, it's a neat process to kind of watch and see, how things change over time. I know there's been other recent changes in recommendations, such as like the screening for type 2 diabetes. The age has gotten lower. And so with all that being said, this study is showing that that aspirin use, they are recommending that it's not used because of greater risks and not much benefit from aspirin use. And so the guidelines are taking into account studies such as this and the studies that this analysis had looked at to help kind of guide their recommendations. I think I see some, oh, those are comments. Okay. Any other last comments or questions?
So quick question. How do we assess risk of bleeding besides like history of a hemorrhagic stroke or maybe a GI bleed? What other questions can we ask to assess risk of bleeding?
Miriam, I'm so sorry. Can you say that one more time? Can you say that one more time?
Oh yeah, sure. So what, like besides history of hemorrhagic stroke and GI bleed, what else can we ask the patient to really assess risk of bleeding?
Yeah, that's a great question. So even talking about the, asking patients about, about falls. So that's a big, factor that can lead to bleeding. So if a patient has like instability and has had a lot of recent falls, so that puts them at increased risk for bleed, right? So that's another way. The GI bleed is definitely a big one. And so I think those are kind of the two main ones that we can kind of focus on as far as like their risk of bleeding. Anybody else have any other like input to that as far as like, asking patients about their risk of bleeding or assessing?
So you could ask, you could see if they have any other conditions requiring blood thinners, like if they have any, hemophilia, not hemophilia, or yeah, you could think hemophilias, but you could think like AFib, are you on Coumadin? Have you had a DVT in the past? Like, are you on a DOAC or something? So, concomitant like anticoagulation or antiplatelet. For any other reason, I would feel like should be considered.
Well, also in elderly, like my dad, if he hits anything, he'll bleed because their skin is really thin. So like, if he could brush against something. So just like the elderly, they're just more fragile people too.
I don't know if you guys remember HESBLED scores that you can calculate, which consist of hypertension, any type of kidney, liver disease, which will elevate the INR, which is another component, stroke, any previous history of bleeding, of course, age greater than 65, and like Brian said, any other medication use that kind of predisposes to bleeding, like NSAIDs, Plavix, aspirin, so and so. And then also alcohol use. If you're drinking more than 8 drinks per week, that also increases the risk of bleeding. And if the score, I think 2 is moderate risk and 3 and above is definitely high risk. So usually inpatient or outpatient also, we people with AFib or need long-term anticoagulation, we compare the CHAS-VASc versus HESBLED and determine the anticoagulation use based on those.
Yeah, thank you so much for mentioning the HESBLED scoring is definitely something that's very useful. And so just to kind of piggyback what Hyunyoung was saying, the scoring, basically they divide the risk group into 4 different groups. I believe it's like relatively, it's like low, moderate, high, and then very high. And so anyone that has a score of 3 and above, so that's in the high to very high group, you want to find alternatives to anticoagulation. So that shows right there that if they have a score of 3 or higher, that they are at an increased risk for bleeding. And so, for a score of 3 and above, your risk of major bleeding is 5.8 and above, which, you know, for that, as far as like number needed to harm, it would be 3.7 per 100 patients per year. So I think, you know, there's lots of, you know, sometimes we don't think about, you know, alcohol use as like a immediate, like, oh, okay, let me associate alcohol use with bleeding. But, you know, if it's a large amount, then that can cause, you know, that can lead to an increased risk of bleeding. And so, yeah, so I think the HAS-BLED is a very great tool to use to assess for the bleeding risk. Any other thoughts?
Awesome. Thank you so much.
Perfect. Well, thank you so much for this opportunity to present this. If you guys have any other questions at any point, please feel free to reach out to me. Otherwise,
Ryan wanted to actually project his screen, so if you'll give me just a moment, I will allow him to do that. Give me 1 second. Okay, Dr. Hen, you should be able to now if you try again.
Here it is.
Okay.
There is
Oh.
a HAS-BLED in what you were talking about.
Perfect. Thank you so much.
And you can see that the risk is significantly higher in this category.
And this
Okay.
table is actually great. It shows, you know, so it's called HAS-BLED to kind of tell you what the different, you know, each letter tells you what you should be asking. So H for hypertension, A for abnormal renal and liver function, S for stroke, B for bleeding tendency or predispositions, L for labile INRs, especially in patients who are on warfarin anticoagulations, E for elderly, any patients that are greater than 65 years old, and then D for drugs, NSAIDs, aspirin, or excessive alcohol use. And so thank you so much, Dr. Hein, for pulling up this chart. And so, like I said, anyone who has a risk or 3 points and above is considered at moderately high or high risk and above, that you should really consider to be at very high risk of bleed. Any other questions, concerns, comments, hellos? Okay, well, thank you so much, everyone, for your time today. I really appreciate it. Like I said, if you have any other questions or comments, please feel free to reach out to me.
Thank you so much, Dr. Shin and Dr. Siddiqui. Also, thank you to everybody for joining us. I did put the link in the chat if you can help us with our feedback, but we just want to thank everybody and hope y'all have a great day.